Hello, I am Dr. Mirela Cerneanu, and I welcome you to the Wellness Optimizing Warrior MD podcast, the WOW MD podcast. I am not your typical wellness coach, and this is not a typical wellness podcast. Here, I'll discuss educational facts about health, hormones, intimacy, anti-aging, and beauty trends, all very hot topics, to empower you to make great choices when it comes to your health and to your body. I want you to go, wow, I did not know that. Or, wow, this is going to make a great difference for me. Our healthcare system is broken and it needs a revolution. You and I can start one today. I am willing to share my knowledge with the world if you're willing to listen. Let's get started. Thank you for tuning back in to listen to this series about fertility. And why do we need to talk about fertility? Because it is very, very important. It is the key of our existence as a race, as a species. And before I start discussing the next two main fertility factors, the tubal factor and the uterine factor, which are the subject of today's episode, I would like to start by giving you some statistics, which will highlight why and how our human reproduction system is so delicate and very easily disrupted by anything, specifically by our environment. So keep in mind, what I'm going to say next is an absolute fact. Only 30% of all conceptions result in a live birth. So that means that 2/3, that's 66% or more, of all successfully fertilized eggs are simply lost. It is estimated that about 30% or more are lost at the pre-implantation stage, which is basically between the time the egg is fertilized and the time the egg is implanted, which is literally the time spent in the tubes, the fallopian tubes, and about 30% or more are lost after implantation, very early on. That is when a woman has a period that is late. So a woman does a pregnancy test, she's a little late. The pregnancy test is either very slightly positive or actually positive. And a few days later, Lord and behold, she starts bleeding and the repeat pregnancy test is no longer positive. So the pregnancy is lost. It is definitely believed that most pregnancy loss that occurs this way is due to poor embryo quality or egg quality or sperm quality, either or. Bad egg, bad sperm, they end up with a bad embryo. So most of the times that means genetic problems. So egg and sperm quality genetic issues, which means the egg normally has 23 chromosomes, the woman's egg, and then the sperm has 23 chromosomes. These chromosomes, half of the genetic material from the egg and half of the genetic material from the sperm combine to give the embryo the full genetic makeup of a human being. Now, in this process of combination, of crossover, when they combine the genetic material, the egg and the sperm, something happens. Whether this is the result of chemicals or toxins or radiation or who knows. But regardless, that results in an either extra genetic material or not enough genetic material transfer. So the embryo ends up with either too many chromosomes or not enough chromosomes. And a lot of these situations are simply incompatible with the birth of a live baby that can survive. So a lot of the times the body knows it has a defective embryo and it will simply reject it. So let me dive right in and talk about the tubal factor and the uterine factor. In the last episode, to recap, I discussed the ovarian factor and the hormone factor. I only separated these two to help you understand there are really two different issues that affect your ovaries. But let's talk about the next factor. Let's presume there's absolutely no issues with your ovaries. They have great quality egg. They have great egg numbers. There are no problems with your hormone balance. You ovulate every month like clockwork. Well, the next problem factor and possible obstacle in the roadmap to pregnancy is the tubal factor, the fallopian tubes. Now, not too long ago, I dedicated an entire episode on this subject. So consider going back and listening. But to sum it up, we need the fallopian tubes to get pregnant like we need water to survive. The sperm travels from the vaginal opening through the vagina into the cervix, the opening of the uterus, and through the uterus to meet the egg into the fallopian tube. That is the egg and sperm meeting ground. Now, the fallopian tube has to grab, and catch the egg once the egg is released by the ovulating ovary on either side. So one of the tubes has to catch it, and then the fallopian tube that caught the egg has to nourish it and propel it towards the sperm. After the egg meets the sperm, the egg gets fertilized. The fallopian tube cares for the egg, nourishes the egg, and will move and propel the fertilized egg, which is now an embryo, towards the uterus. Once inside the uterus, the fallopian tube's job is over. Now, the tubal factor is a major issue, especially with unexplained fertility, where there is normal sperm and normal ovulation. And I say unexplained fertility issue because the tubal capture and egg transport is such a crucial step in the fertility process. So if the tubes do not work as they should, no woman is able to get pregnant. So is there a way that we can test the functionality of the fallopian tube? Well, we can test it by doing a hysterosalpingogram. This is a test performed in an imaging center by a qualified radiologist. Usually, a small plastic tube is placed through the cervix into the uterus, and then a fluoroscopy dye that's radio-opaque will be pushed through the syringe into the uterus, through the syringe connected to the tube, into the uterus, and then the radiologist will watch on the screen the progression of the dye into the uterus, the way it spreads into the uterus, which highlights the shape of the uterus. And then it will show whether they're filling defects, suggestive of masses inside the uterus, a fibroid, a polyp, an IUD. And then ultimately will progress through the tubes. It will pretty much highlight and show us exactly the shape, the length of the tubes, whether there's kinking of the tubes, abnormalities, the tubes are too short, too long, and whether or not there is spillage of this dye into our abdomen. That means the tubes are open for business and they're able to grasp the egg from the ovary and propel it along. Well, backtrack a little bit. It just means that the tubes are open and they should be able to grab your egg from the ovary. Now, how do we know that the egg is being propelled and nourished? We don't, because this test does not tell us how is the inside of the tubal lining working. It does not tell us at all if this delicate lining of the fallopian tube, which is capable and absolutely needed to nourish and propel the egg and sustain the embryo throughout its first stages of development, it doesn't tell us if it does a good job or not. So this hysterosalpingogram can only tell us if the tubes are open. That's it. So we do not have a test for how the tube actually functions and how effective it is in sustaining the embryo. And that is why the saying that I mentioned earlier in another podcast episode comes into play, where I said ovulation is a law of nature, but implantation is a law of God. And I didn't say that, somebody else did. But there are so many unknowns and so many complicated issues that could come or arise from a poor quality fallopian tube environment. And that is likely why there's so many cases of what we call unexplained fertility. Now, I would like to continue the discussion with the uterine factor this episode. But in the next couple of episodes, I will also come to discuss the cervical factor, the vaginal factor, endometriosis, and how it causes infertility. And then last but not least, unfortunately, unexplained infertility. So we will talk more on this subject. So let me talk about the uterine factor. I talked about and explained the ovarian factor, the hormone factor, the tubal factor. And now here comes the uterine factor. This is a very big one. This is where the embryo will burrow and develop into a fetus, and then a baby that will be born in 9 months. The uterus, first and foremost, has to be ready to receive and allow the fertilized egg to implant and then grow. And in order for implantation to occur, that means that the uterus has to be baby-friendly. So let me explain this a little more. It means, in simple layman terms, that your uterus needs to have a certain thickness of the lining at the time of the arrival of the embryo from the tube. Now, the good news is we can measure the lining of the uterus with an ultrasound. Best time would be about 5 to 6 days after ovulation. That's about day 21 of the cycle, if a woman has a 28-day cycle. And ideally, we want to see that the lining of the uterus is at least 12 to 15 millimeters thick. The lining of the uterus on ultrasound also has a typical appearance. It looks rather clear, like a set of 3 lines. So it has what we call a trilaminar appearance. And that is important because a uterine cavity with a lot of polyps that looks really funky on the ultrasound might not be able to sustain and allow implantation. If the lining is thickened abnormally and unevenly, you can see that it's thicker at the fundus, thicker in the middle of the body, thinner at the fundus, thinner at the bottom. So you can see all of this on the ultrasound. So if that happens, it suggests polyps or hyperplasia, and that should definitely prompt an evaluation of the uterine cavity with an imaging test. I want to backtrack a little bit when I talked about the ideal uterine lining thickness. Some literature, if you research online, says minimum 7 to 8 millimeters. That is not ideal, and it could be far from optimal. Let me tell you why. Because the acceptable thickness for the uterine lining for a woman that's menopausal on hormone replacement therapy, it's about maximum 7 to 8 millimeters. So it's about half the size of the optimal uterine lining at implantation, which, as I said, should be closer to 15 millimeters. Why is that important? Because a menopausal woman on estrogen or a woman that's naturally ovulating should not have a lining in the middle of the cycle past ovulation that's 8 millimeters or below, because that just means that there has not been enough exposure to good levels of estrogen and progesterone, okay? Because a menopausal woman on estrogen therapy that gets to a lining that's maximum 7 to 8 millimeters will not have anywhere close to what a young woman has in estrogen and progesterone. We don't want to replace estrogen progesterone to the levels where we promote fertility. That's not needed. We just want to control symptoms and have no side effects. So 7 to 8 millimeters is too little. Close to 15 millimeters is better. So we need hormones to develop that lining. So let me talk more about that. Now, the uterus has to have this certain thickness, this certain lining that definitely develops under the influence of estrogen. I made this analogy in multiple episodes now, and I'm going to revisit it for you one more time. Imagine that the lining of the uterus is a brick wall. The bricks are the estrogen, and the mortar that holds the wall together is the progesterone. In the normal phase of the ovarian cycle, once you start your cycle, you have your period, the ovary starts producing estrogen. Estrogen will make the lining of the uterus grow in the first 14 days. After ovulation happens and the hormones peaked, the ovary now makes progesterone, which is needed to allow the uterine lining or the endometrium to thicken even further. Progesterone stimulates the glands of the uterine lining to grow and produce the nutrients that are essential for the early embryo to be nourished and to allow continued growth of the embryo. So I might come back and make an entire episode on what can we do to help along and cure different conditions that affect and influence the fertility factors I'm talking about. But for now, let me focus on the what can go wrong. So what could go wrong with the uterus? Well, there are anatomic problems that affect the uterus. For example, when a woman is born without a uterus, or when a woman has a somewhat deformity of the uterus. Let me expand on that. In the process of the uterus being formed, when a woman is a baby in her mom's womb, she starts as a female embryo. So in that embryo, fetus, baby, the uterus develops from two halves that fuse in the middle. That's why there are two ovaries, two tubes, and then the uterus fuses in the middle, the cervix fuses in the middle, the vagina fuses in the middle. So any problem with that fusion will create an issue. During this process of fusing, there could be fusion issues due to mostly various environmental factors and possible exposure to chemicals and hormone disruptors that will create a problem with this fusion. So the female baby, which later becomes a woman, can be born with a uterine abnormality. For example, the most commonly known is a uterine septum. That's a membrane that divides the uterus in a third, a half, or all the way down when the fusion is either partial, so incomplete, where the septum is just at the fundus or top of the uterus. And those are actually pretty serious because most of the implantations occur at the fundus. It's a statistics law. I guess that's where the most surface of the uterus is. So, and that's where the tube pretty much spills it right out at the fundus. So if you have a septum there, which is probably not a good viable territory for the lining to develop really well, because this septum, it's actually fibrous, it will make it very difficult to implant. In some cases, the separation is all the way down, so the woman can actually have a double uterus. That makes it even harder to carry the pregnancy. It's not difficult to implant, but makes it harder to carry the pregnancy and will increase the risk of preterm birth. The uterus is half the size of a normal uterus, so it will start contracting and not tolerate the development of a baby all the way to 9 months. So it might want to give birth earlier at 6 months, 7 months. Luckily, it might go to 8 months. Those situations are rare, but not impossible. You should know about them. They're actually quite common. I've had quite a few patients in my career that had these issues, but they only account for about 3% of infertility cases. The biggest issue with the uterine factor comes from 3 conditions: uterine polyps, uterine fibroids, and scar tissue called synechia. Now, I talked a lot about fibroids in a previous episode. We call them myomas, leiomyomas. Some women just call them cysts. They are benign tumors and they develop inside the uterine cavity, or actually inside the wall of the uterus. They disrupt the uterus, they create a distortion, and they deform the uterine cavity. Now, the majority of women who have fibroids have no symptoms. That is why having an ultrasound as part of the fertility workup is very important. When fibroids are causing symptoms, most of the time these symptoms are either heavy periods or bleeding outside of the scheduled period, either a week before, or the period comes and lasts a long time, or they're bleeding right in the middle of the cycle. There's back pain, there's abdominal pain and cramping. The periods can be very painful and long. The woman might feel bloated or distended in the lower abdomen. Again, please go back and listen to my podcast episode about fibroids for more details. These benign tumors, what's important to know about these tumors and fertility is that they could distort the shape of the uterus, and they can unfortunately block the fallopian tubes. They can also change the shape of the cavity and the size of the uterine cavity, which unfortunately interferes with the implantation process and creates an increased risk for early pregnancy loss. Now, let me be clear about this. Many women with fibroids get pregnant very easily and carry the baby all the way to term. And only a small percentage of women with fibroids have actually significant difficulty conceiving. And that's estimated to be about 2 to 3%. Now, those women could benefit from early on additional tests, MRI for exact location of the fibroids, a very clear detailed ultrasound, hysteroscopy, and ultimately possibly removal of the fibroid called myomectomy. Keep in mind that the type of fibroids that are very close to the uterine lining, that affect the uterine cavity by bulging into it or by closing it off, those are mainly submucosal fibroids, and these will be the type that require surgery. Otherwise, carrying a baby to term might be impossible. Now, you might have fibroids within the wall, not submucosal, so not necessarily interfering with the lining, but they could come very close to the lining. That could be a problem because the implantation needs very healthy tissue to burrow into. So a very large fibroid that's affecting a very large part of the uterus might need to be removed to allow for healthy implantation. Again, that's called myomectomy. It can be done laparoscopically, same-day surgery. It needs to be a very clear discussion about the position, the location, the size, the age of the woman, and the fact that all the other factors have to be perfect in order for this surgery to be successful or considered as indicated. So keep in mind, most women that have fibroids will get pregnant easily. Unfortunately, a lot of them could miscarry early on due to what we call implantation failure. We do know that quite often women with fibroids in any location of the uterus can have significantly lower rates of pregnancy, live births, and a higher rate of miscarriage. Now, that is mainly true for submucosal and intramural fibroids, the ones that are developed inside the uterus and right really close to the uterine lining. These fibroids are always surrounded by something called a pseudocapsule. It's just a thickening of the tissue around the fibroid that makes it very easy and nice during surgery to remove a fibroid. We're just going to shell it out. But these capsules, which can vary in thickness and are apparently much thicker in submucosal fibroids, these capsules secrete neurotransmitters and have a much higher expression of the hormone oxytocin. Now, as you know, or if you don't, let me remind you, oxytocin, it's a hormone that creates uterine contractions. And this is a problem because if we have fibroids whose capsules are making these oxytocin in large amounts, when the embryo arrives in the uterus at this point, after all the hormones and the nutrients that are present and the body has made and everything is bathing the embryo in it, the embryo will need a very quiet, steady, still environment, meaning the uterus cannot have contractions. Because if we have a lot of fibroids in the uterus that make this oxytocin hormone that would make the uterus contract, it will simply allow the embryo to just be pushed outside of the uterus into the cervix, where it will just not implant or lead to a cervical pregnancy, which is a very bad situation. So bottom line, these intramural, so inside the wall fibroids, can produce neuropeptides, which will create muscular contractions of the uterus at the time when the uterus needs to be still. And this is why women with fibroid uteruses have a much higher rate of miscarriage and preterm birth. Let me continue to talk a little bit more about the process of implantation. This is the process where the embryo embeds in the uterine lining and attaches to the wall. And this is due to a molecular sticking process. You actually need to have this sticky stuff which stops the egg's progress down the uterine wall towards the cervix and actually will start the attachment process to the uterine wall. That's the first stage of implantation. And this is crucial information to know about this process. Why? Because 3/4 of the lost early chemical pregnancies where there's a failure to implant are likely due to a problem with this attachment process. This is where the law of God I talked about comes into play, which pretty much from a medical science standpoint says there's a lot of stuff involved in this and we have no clue what it is, but we're doing research into it. But think about this. Everything up to this point went really well. You made an egg. You had the egg fertilized by the normal sperm. It traveled all the way into the uterus. You had a beautiful fallopian tube. It nourished and propelled the embryo. The embryo arrives. It is ready to attach itself. And somehow this attachment process fails. And there's a lot of stuff that we can do science-wise. We can stimulate more eggs with medication. We can capture the eggs, bypass the tubes, fertilize the embryo in a tube and put it in the uterus. We can do all kinds of things, but we can do nothing, as far as we know now as it stands, about this attachment implantation process. There's so many things and cellular processes that need to align and to happen just right to make it perfect and okay for the embryo to burrow into the uterus and allow for 9 months of development, that it seems almost a miracle that it happens so often and so easily for so many women. Now, I remember reading a book called Is Your Body Baby Friendly? And this is where this whole unexplained infertility comes into play. And it's a good book. So if you are trying to get pregnant and having issues, please buy the book and read it. There's a lot of esoteric stuff that you probably can flip through. But to me, that was an eye-opening book, but it was also very depressing because I realized at the end of the book, I was not baby friendly. Actually, I realized that probably halfway into the book, if not earlier on. I was not baby friendly at all. I expected nature to accommodate my desire to have a baby and give me what I wanted when I wanted it, in spite of the fact that I was being overworked, sleep deprived, and stressed beyond probably normal limits. I believed at that point that it was enough to make my body baby friendly when the baby was there. I had no idea I had to change my life to allow for it to happen. I was literally going to slow down, work part-time, and avoid the stress and all the crazy stuff after I got pregnant, not realizing that my lifestyle was a major obstacle for my body to allow pregnancy. It was one of those things in my life I could not simply will into existence. God and fate had other plans, and I bowed my head with humility and embraced it. Well, not after fighting for 5 years for it. However, outside of all this journey for fertility, I gained a lot of stuff. I had brand new education. I gained the knowledge of how important it was to consider my health first and reassess my priorities. I realized that the current job at the community health center was slowly and surely aging me and making me sick and unhappy. So I decided to start my own practice. The only thing that I birthed after my fertility journey was my private practice. The result was my decision to practice medicine on my terms using newly acquired HRT education, knowledge about the anti-aging, restorative, holistic medicine. All this education made me fall in love with medicine again. That feeling was awesome. Once I decided it was the right thing for me to go, I remember my first 3 years in practice were absolutely awesome. I had to build up the clientele. People had to get to know me, send me friends and acquaintances. Those were beautiful times. I was busy, but I was not crazy busy. Practiced yoga every day. I had a mental health day. When I took horseback riding classes, I got massages. I was home planning recipes to cook. I was catching up with house chores. I worked when I wanted, as much as I wanted. Unfortunately, as I got busier and busier, it all went out the window. Now I have to get it back again, which is why I'm focused on selecting and training the best possible mid-level providers to help me with the work I have. So I can get back to those times when I can have my own personal me time. Why did I take this little detour? And I apologize for taking so long to talk to you about my stuff. But I believe that this me time is crucial and that being in a happy place and being happy about your life is a must when you embrace your fertility journey. Again, I digressed a little bit, so apologies. But sometimes a shared experience is as valuable as facts because there's a lesson in each one of the shared experiences that someone shares with you. But anyway, let me get back to the uterine factor. So the embryo arrives into the uterus. It needs to find a spot where it could implant, burrow, invade the lining first, and then stop right at the muscle to allow for the development of the placenta. So this is a crucial process that needs to happen a certain way, and the uterus needs to be ready for it. So to sum up the uterine factor, any disturbance of the lining could impede the implantation process. Polyps, fibroids are the most likely culprits. That's why an ultrasound done right at the end of the period, around day 4 or 5 of your cycle, of your menses, could tell us a lot about the appearance of the cavity. There are polyps, there are fibroids, and if that's not clear, a hysteroscopy, which is a very simple procedure done in the doctor's office, there's a camera that can be placed inside the uterus, through the cervix. We would distend the uterus with a sterile fluid, and that would make it very easy to see inside the uterus. We can see the openings of the fallopian tube. We can see the types of the lining that we have. And if we see a polyp, we can actually take a biopsy, remove it. And sometimes if we see a fibroid, we might need to do a fibroid resection. It could also tell the doctor that's doing the procedure if there's scar tissue present in the uterus, called synechia. I mentioned this earlier. This will have to be debrided, dissected, chopped away, and then a woman needs to be given large amounts of estrogen and then progesterone to stimulate the regrowth of lining in that area. And that would be a very simple treatment. There are many mysterious and barely discovered amazing things that happen at the cellular level to allow for this magical process of implantation. What you need to take away from this podcast is that this process is highly influenced by our hormones. We need a critical level of progesterone to allow for implantation because below 5, progesterone of 5, it is likely impossible to get pregnant. The uterine lining has to be baby-friendly. And though we don't know exactly why some embryos simply fail to implant, and again, that's a pill that's very hard to swallow as a woman and as a couple, especially after both you and your husband or partner spend tens of thousands of dollars on a fertility treatment cycle, even though we don't know exactly why some embryos fail to implant, this is why starting to look into your health and wellness and checking your hormonal balance and your cellular health and investing in your cellular health and your metabolic pathways, maybe 1 to 2 years before pregnancy is planned, would allow a couple to uncover potential pitfalls, problems, resolve them in time in order to allow for a successful natural or assisted fertilization, then implantation, and finally, a live birth of a beautiful baby. Please join me next week as I continue on this fertility journey as I tackle some of the remaining fertility factors. Thank you so much for listening. If you are one of my faithful listeners and you are finding value and enjoying these episodes, please feel free to leave me a review on whatever platform you're listening to. Also, if you find the content in these topics useful, not just to you, but to someone else, a friend, a loved one, or simply an acquaintance that you know could benefit from the knowledge I share here, please feel free to forward my podcast to them. If you live in California and you'd like to work with our practice to help you achieve your wellness goals, please go to our website, www.herabeautyandwellness.com, and request an appointment. It will be our privilege to help you in any way, shape, and form we can. Any suggestions on a topic of beauty, wellness, or anti-aging are welcome. All you have to do is go to the website, leave a suggestion into the AI chat, and I promise you if you ask, I will listen and add your suggestion to my list of topics that I want to get to as soon as possible. Please join our Facebook group, The Wellness Optimizing Warrior MD. It's a small growing community that focuses on wellness, on what's new, what's safe, and what works in beauty, wellness, and anti-aging.